It depends on multiple things, but we have had soldiers, service members injured, and within 24 to 36 hours they're here. A soldier injured in Afghanistan, Iraq, wherever it may be, is going to get the initial care there on the battlefield, and then based on their injuries, they will be evacuated back here to the States. So there may be more than one facility that can provide the specific care they need. When possible, they will choose the base or the hospital closest to their home station so they can be closest to their family. So it's predicated most importantly on what their injuries are, and then when they can be treated at the facility closest to where they're from, they try to combine those two things. And if not, they bring that family to be with the injured, soldier or service member. We have traumatic brain, we have straight up medical critical care issues, we have traumatic issues. So as they come back through the evacuation pipeline or evacuation transport chain, they end up where we can best give them the care that they need. It depends. If you're injured in the local South Texas area, you're coming by helicopter or ambulance. If you're coming from overseas, what will happen is at some point you're done being on a helicopter and then they're flying you on the big planes, and most flights land at our Air Force military base here, and then they're bus or ambulanced over here to us. So there are so many, and there's a massive amount of research that's been done here in the military, the Department of Defense here as well, but some things are very common sense. We want to get people from the point of injury back to a level of care as quickly as possible. We definitely want to make sure that for those who require them, they get tourniquets as quickly as they can in the field for those types of injuries, and we're saving so many lives, and all those advances have happened since the beginning of the war as we've looked at the data and recognized where we could improve care. So I would tell you those two things: the rapid, effective evacuation and establishment of evacuation plans, as well as treating the things, especially like things that, limb losses that need a tourniquet. To have arguably the world's greatest burn unit, and clearly one of the top 2 or 3 in the world, is immense. We have expertise and training here that is phenomenal, and all the service members benefit from that, as well as South Texas, because burn injuries from all over South Texas also come here preferentially for their care. And so we're constantly improving and getting better and finding ways to do better skin grafts and treat the burns, and so it's a luxury to be able to know that you're at a place where the best burn care in the world is rendered. It is always challenging due to the constant turnover in personnel. People come here, they get set for deployment, they're here for 2 or 3 years, they get a new assignment as they grow and change and mature. And so having a consistent, the same people trying to maintain the same decisions and moving forward. But at the same time, that I think is a large strength, because you learn to build teamwork quickly, learn to trust each other, because when you go downrange as part of a unit, they don't just take you as your unit from BAMC, they take a physician and nurse from here, another physician and medic from there, administrator, and so you all have to come together very quickly. So constant turnover is probably one of the biggest challenges we have, but at the same time, that constant turnover prepares us for. I think emergency medicine is a continually evolving specialty from the standpoint of our population continues to expand. There are not enough providers to see people for their routine medical care. And so more and more people seek care in an emergent environment, which is why there are so many emergency departments around town, around the state, around the country. The ability of emergency medicine providers to work with their colleagues and the other specialties and provide an area where many things can be done. Specialist X can come in and do a procedure, specialist Y can get a particular evaluation that's unique to their specialty, is going to be key. So here we've developed a pediatric pod to help take care of pediatric focused injuries. We've also built a acute care or a rapid treatment provider program so that when patients come in who are of lower acuity, we can see them very quickly and efficiently to get them back home but they also then don't slow down, or they aren't forced to wait for the sicker patients, which we see in a different area of the emergency department. So the ability to care for children, the ability to care for less sick but people who need care now, and that critical patients who come in who are sicker and need more resources and time, I think we'll have to balance all of that with the cost of medicine, because medicine is expensive nationwide as it continues to grow as part of the GDP and everything else. And so we need to find a way to efficiently deliver care to more and more people.